Dr. Chana Davis, a geneticist and contributing writer at Those Nerdy Girls, and I'll be your host today. I'm joined by Dr. Jenn Dowd, our amazing editor-in-chief. Jenn is an epidemiologist and demographer who studies mortality trends and how social factors get under the skin to impact health, including via infections and immune function. She's a professor of demography and population health at the University of Oxford and deputy director of Oxford Leverhulme, how do you pronounce that?
Yeah, I say Leverhulme.
Leverhulme, okay. Center for Demographic Studies. Jenn grew up in Nebraska and Texas and currently lives in London with her husband and 3 teenage children. So
Hey,
over to you, Jenn.
yeah, it's great to be here today. Yeah, thanks for having me, Chana.
All right. So as a reminder, we don't take questions cold, so we always have the best resources and links available for you, but you can always submit a question on our website at thosenerdygirls.org. So let's get started. The first question here is kind of a biggie. It came into our inbox from many different people over the last few weeks. So Jenn, I'm going to let you tackle this biggie. What is your take on the recent Cochrane review of masking to prevent COVID-19?
Yes, indeed. Study has gotten a lot of attention over the past few weeks, and we totally understand how confusing these types of headlines can be. And so that's what the nerdy girls are here for. We're going to try to break it down and make some sense of it for you. And so to recap for anyone who may not have heard about this study, there was a recent Cochrane review that I'll describe what that is in a second, but it concluded that there was insufficient evidence that masks were effective in reducing respiratory illness. So obviously that was kind of a concerning headline. But what is a Cochrane review or a meta-analysis? These reviews really do an important service for science. They try to summarize and draw conclusions from a large number of studies in what's called a meta-analysis. And in this review, the authors were looking specifically at studies that were randomized control trials, meaning that the use of masks was randomized in some way with a treatment and control group. So this is kind of like we do for vaccines or other medications in clinical trials. But of course, we really like evidence from randomized control trials because ideally it helps us to better pinpoint cause and effect. In comparison, we have observational studies that can be harder to interpret because if we just look at people who mask frequently in real life compared to people who don't and measure their chances of getting infected, it wouldn't be surprising if people who mask frequently had fewer infections. And this isn't just because of the masks, it's because people's health behaviors are often bundled together in a sense that people who wear masks are more likely to be up to date on their vaccines and be conscientious about all sorts of other health behaviors. So that's why it's hard to determine cause and effect from these observational studies. And we really do appreciate these randomized control trials and RCTs as really important evidence. So this meta-analysis, which combines the results from lots of different studies, basically it seems like a really good idea to try this and see what the evidence is. But one key to a good meta-analysis is that the RCTs that you're combining should be addressing the same question in the same way. And so for a clinical trial with a drug, this isn't too hard. It might be the same drug, maybe a different dosage. Things can get tricky. But in something that's a little more real world or behavioral intervention like masks, this gets even harder. And this is where I think the main area where the Cochrane review is really limited. Basically, we have what we call an apples and oranges problem. Mask experiments are harder than a clinical trial for a new drug. They happen in lots of different settings. And so this analysis combined studies that were very different, studies that had combined looking at surgical masks versus N95 respirators, continuous versus occasional mask use, and different settings, healthcare and communities, et cetera. This wasn't nefarious. This was just the way the RCTs for masks had been done over the last many years. They're just not as controlled in the way that drug trials might be controlled. But the problem is that this really limits, what we can conclude from combining all of these studies together. Because we know that COVID is spread through aerosols, these small particles that can linger in the air like smoke. And that's why, studies that include medical masks or surgical masks and assume that they're the same as N95s are really problematic, because medical or surgical masks are meant to block droplets, especially the spit that might come out of a surgeon's mouth if they're operating on you. So we're all grateful for that. But these masks really leak a lot of air from the sides, and they're not meant for true respiratory protection the way N95s are. And so combining studies with surgical masks and N95s are really combining apples and oranges. And there was a really good quote in the conversation piece that we're linking to that says, if apples work but oranges don't, combining all studies into a single average number may lead to the conclusion that apples don't work. So it's really just something that makes it hard to interpret. And so then saying there's insufficient evidence isn't really that convincing. And there were some other issues with this study. If you read our post on this, you can read a few more. There were only 2 studies that happened during COVID itself. Most were based during flu or other respiratory illness seasons.
I think that's a really key point.
Right? Yeah.
Yeah.
No, and those are, so much less transmissible than COVID, actually.
Mm-hmm.
And that makes it a lot harder to detect any effective prevention. And this is something we see with clinical trial RCTs as well, with something like vaccines. If there's no transmission of COVID, we can't detect an effect of a COVID vaccine either. So if you're doing a mask trial in a period of very low transmission, it's just going to be very challenging to find an effect. But in healthcare settings where the risk is often higher, that's where we've gotten some much better evidence that high quality respiratory protection does limit transmission. And so, that's really not debated in those settings at all. But you're probably wondering what this means for you, because it's a little disconcerting to hear something that says masks don't work. And I'll just say that randomized control trials are a great way to build evidence for many questions, but they're not our only source of evidence. There are things like the benefits of seat belts, bike helmets, airbags, even parachutes that we trust really based on basic physics and engineering, combined with, controlled laboratory experiments like crash test dummies. And we have a lot of that other type of evidence from engineering and lab experiments that masks, and by here we mean the high quality masks designed for respiratory protection, that they do physically block both inhaled and exhaled aerosol particles that carry viruses. It really is, that simple. And so to me, at the individual or personal level, it's just a no-brainer. If there's a situation where you have COVID and don't want to spread it, or where you have a good chance of being exposed because you're on a plane or a family member is sick, or you just want to be careful around a vulnerable loved one, a mask is a great way to dramatically reduce, your risk of getting infected or infecting someone else. And masks aren't perfect. A lot depends on the wearer, but the risk reduction is real and significant. And I really don't think this is open for debate. I like to think, if really, God forbid, we had another pandemic, something like this avian flu that has a much higher fatality rate, that would be very scary. But I strongly suspect that if that happened, that a lot of the mask skeptics today, might be the first ones to pop one on to themselves or their kids, because it's just true that it's a physical barrier and does prevent infection. And I won't go into as much of why I think this is controversial. I think part of it is the difference between individual level effectiveness and then scaling that up to the population level, where not everyone complies. So saying that a mask is a physical barrier and works is not the same as saying a mask mandate will work at the population level. And I think that's where some of this miscommunication comes. But the bottom line is, I think, despite this evidence to the contrary that you might be hearing, there is really good evidence that masks are effective in reducing the risk of transmission and infection. And so, especially for you yourself and decisions you're making to protect your family, we still strongly recommend masks in the right context. And
I'm glad. I'm
I'll
glad
leave it
that like this has been quite a deep dive, more than we usually go into most questions. But I think it's important because one of the part of our mission as Nerdy Girls is this general science education, and just reflecting on some lessons here. One is that you need to always think about mechanism as like a huge aspect of whether or not something makes sense, and we have a very strong mechanism here. And the other piece is you need to look at the whole body of evidence. And this Cochrane review only focused on the RCTs, which are always an important piece, but then you need to go a layer deeper and see how relevant were they to the question we're actually trying to ask.
Yeah, exactly. And I understand why when you see, isolated headlines, it's very hard to put into context. So that's kind of what we do for a living. So we're here to
Yeah.
try to help. Okay, now I have a question for you,
Okay.
Chana.
Actually, sorry, 1 second. Let me just drop the links that I promised that we would share.
Okay, sure.
You had a great post on this particular topic, and I'll share that. This is going to pop up in the Facebook, I believe, but I don't know if it goes to every other platform. Yeah. And one more from the conversation article, and then we'll move on to our next question.
Yeah, and you can always check out our website to find those posts we've written on this.
Okay, next question.
Okay. So this definitely comes up a lot. There's people who, seemingly take a lot of risk, and never get COVID, and other people who are super careful and have gotten it a few times. So do we know why some people seem to dodge COVID, even when they seem to be taking risks?
Yes, we have some idea. We don't completely understand, the specific factors in every individual case, but there's a number of different factors that impact this. And let me just I always like analogies, and one analogy here is, you can smoke your whole life and not get cancer. It doesn't mean that smoking is not associated with lung cancer. It's very rare that we have these absolute perfect associations, even when something is fundamentally true, like a risk elevation. So this is all about risk elevation, right? And nothing's going to be 100%. I think even if you expose someone directly to SARS-CoV-2 virus, you can't be guaranteed they're going to get it. And there's anecdotes of people who tried to get it from their kids, so they got all get it at once, those kinds of things, and they failed. But I think the first layer of this is we don't always know whether or not we've had COVID the way we think. Some people think I've never had it. And actually, if you look at their antibodies, they have had it. But either they were asymptomatic or they had, cold symptoms, but tested and were negative. And so the test didn't detect it. So I think that's actually a pretty substantial proportion of the population of people who think they've never had it, but have actually had it. And then before we had any testing, there's people the other way around that thought they had COVID, but actually it was something else.
Yeah, that's what I was saying. Everyone thought they had it in March 2020, but there were just a lot of colds going around.
Yeah, and I wish I could find it, but I know there are some what they call seroprevalence studies where they look at what percentage of the population has antibodies, natural antibodies, not from immunization against COVID, and it doesn't always align with people's expectations of what proportion of people think they've had it. So I think that's a big component of the answer to this question, is that there are a lot of people who have actually had it but don't realize that they've had it. Especially with kids who can often be asymptomatic. I think this particular question came from someone who was older, and I think it's less likely to be asymptomatic or mild when you're older, but it is still possible to have a mild case and maybe to not test positive. So that's certainly part of it. But just taking a step back in terms of just the broader factors that impact whether or not you're going to have, a detectable case of COVID. One is your immune status. And so that relates to both, because there's something called an abortive infection, where basically, when the virus enters your body, you kind of have this tug of war between your immune system and the virus. And if you win quickly enough that you're not symptomatic, that's kind of, did you have it or did you not, right? It's actually not really black and white, the definition of did you have it, did you not? Like everyone's basically been exposed to it, but did the virus kind of win that tug of war and take off into exponential growth? And that's sort of the way we would define having it testing
seems
positive,
impossible,
right?
Yeah, that people haven't been exposed by now. I know there's some surveys here in the UK that suggests that everyone's been infected. Like there's been enough infections that everyone in the population could have had it 2 or 3 times. So yeah, it's been very widespread.
So some people might have had that encounter and just won the tug of war. And why did they win that tug of war? Probably because they had pre-existing antibodies, either from vaccination or from natural immunity. Well, that doesn't make sense for the first time, but yeah, they will have seen it before. Or the other thing is they might have actually seen something similar in their past. So you could have something in your immune system that is, you've encountered a virus in the past that had some commonalities. And so therefore, some of those same memory cells that are stuck around from an infection years ago might have actually helped you to overcome the SARS-CoV-2 infection. So that's where it varies from person to person. If your entire immune past affects the repertoire you have now, which impacts like how you respond to whatever pathogens you encounter. And another layer here is your genetics. And so the virus has to enter your cells. And one of the important receptors on your cells is the ACE2 receptor. And that is a receptor that can vary significantly from person to person in, how much it's expressed and so how easily the virus can enter your cells. And that people think, for example, that might explain why children might have milder infections, that they maybe have lower levels or something. There's age-related changes, and that could factor into the course of the viral infection. So there's age-related factors there, but there's also just inter-individual differences in what's on your cell surface, and therefore the ease with which the virus can enter your cells. And then the other big one is the environment and the behaviors. So but like we said earlier, even if risk is relative. So this person is viewing their friends' behaviors as risky, but I don't think those people are actually, going into a room and inhaling the virus. They're just not as cautious as these people who are very cautious. These people are, traveling the world and, having experiences, but it doesn't mean that you necessarily were exposed to a very high dose. And so there's an element of luck there. Like even if you've been exposed to someone who was sick, how much virus were they spewing at that time, at that moment?
There's so much
an exposure does not guarantee an infection.
Yeah, we really do like to think that everything is deterministic, but there's so much randomness and luck in all of this infection spread.
Yeah. And I honestly believe that, and I think most experts would say this, there's probably only a very small fraction of the population that are truly immune and that will never test positive. The rest of us will test positive if we test frequently enough. If we tested daily, for 3 years, we would get a positive test at some point. And I know people who are, I didn't get it in 3 years, I'm never going to get it. And then, then they get it. There's still people who are fallen, that thought that maybe they were immune, but they're not.
Not many left, but
yes. So don't assume that you will be a forever COVID virgin just because you are so far, or you think you are so far. I'm just going to drop a post to a link here to a post that we did on the Nerdy Girl site, and also a conversation, or a Guardian article actually on that one.
Awesome.
So let's move on to another question for you, Jen.
All right.
It's about boosters. This one comes up a lot as well. So I'm fully vaxxed, and so when can I get my next booster? This is somebody who had their primary series and has had a bivalent booster. Now what?
Yes, we've been getting this question so much, especially because people got their bivalent booster right when it started in September, and many months have passed. So, can you get another one is the big question. And sadly, here in the US, there's currently, no recommendation or authorization to get an additional bivalent booster for anyone. And we know that's not a very satisfying answer for a lot of people, but unfortunately, that's kind of where we are at right now. And this, current guidance is based on recent meetings of the VRBAC and U.S. Advisory on Immunization Practices meetings, those both advise the FDA and the CDC. And they've had a couple meetings to discuss the future of COVID vaccines in the last couple months. And what really seemed to come out of these meetings was that the U.S. seems to be moving towards an annual updated boosters, but with flexibility, as they say, for the most vulnerable if the situation changes. So the guidance, could change if circumstances change. And these discussions, are really interesting. The link to our post has some links to the meeting slides if you want to go really deep. But they acknowledge that people over age 65 or who are immunocompromised remain more vulnerable to severe COVID outcomes and may benefit from more frequent boosters. But they really just concluded that there wasn't evidence right now, sufficient evidence to recommend those additional boosters. And the good news is that hospitalization rates for older adults who've received the bivalent booster remain low. And so this is important because we do know that protection from any infection or just testing positive wanes a few months after any of your jabs. But protection against severe disease and death seems to be more durable. But because, everything with COVID is still new and hasn't really fallen into a true seasonal pattern, we really need to be alert and flexible if things change. And so the ACIP committee said they would be on the lookout in order to reassess the situation for any increases in hospitalization from those who've had the bivalent booster, any other evidence of waning, measuring antibodies or other things, and any new variants. I think this is probably the most likely thing that might emerge that have a higher degree of immune escape from our current vaccines. And so as that landscape changes, these recommendations might change. So I think that's the good news. But one of their considerations, I think, in this decision was around confusion and messaging about these boosters. Only 41% of Americans age 65 and over have gotten the bivalent vaccine. So definitely still go get yours if you haven't. And despite all of our nerdy girl efforts, a lot of people seem unaware that the bivalent booster is something different that they're eligible for. They might have had that third shot of their primary series that we call the booster. So part of the desire here, I think, from these committees was to move to an annual approach that might simplify recommendations and hopefully increase uptake. So, it's debatable, but I think that was one of the considerations that they had. And we know that from a lot of your comments that to some of our posts that many of you who are immunosuppressed or otherwise at higher risk are quite frustrated by this decision and kind of wondering if you can find a way to go out and get an extra booster yourself. And we kind of put this question to our nerdy girls who are clinicians, and we have to say they were quite reluctant to say that you should or could go off label to get an additional bivalent booster. They said it's technically probably legal, but there are risks to both the patient and clinician prescribing. So they really didn't know anyone who would recommend it. It leaves clinicians open to harm from the vaccine if anything happens. Also, the patient might not be protected, able to claim anything if something happens. And insurance companies are not likely to cover the cost of something that's not authorized. So, perhaps it's something to discuss with your clinician if you're really concerned about your risk. But it doesn't seem like there's an easy workaround at this stage if you're keen to get boosted again. And just an interesting fact that across here in England, where I live across the pond, they are planning to do spring boosters for over 75, if you're over age 75 and immunocompromised. So that's a little bit different. But the bottom line in the US is, we might be headed to a fall or annual booster campaign, but there's some flexibility baked in if circumstances change.
Right. Thank you. That's hopefully all the information people need right now. It's unsatisfying, I know, but it's at least you know that you're not missing out on something, right? You're not there's not some place that you haven't looked at that you can find your answer. So I dropped a link to the Nerdy Girls update in our links there.
All right. So we'll keep you updated if anything changes.
Definitely.
All right. Question, a non-COVID question for you.
Okay.
Is it true that erythritol causes a greater risk of heart attack and stroke?
All right. I am happy to answer this question because it's a great, science literacy and media literacy type of question. So I'm going to approach the answer from there without getting into too many gory details about the precise study. But the short answer here is this is a good example of the media, blowing things up prematurely. So I would take this headline with a grain of salt. So what is erythritol? It's a sugar substitute that's become popular in the last few decades because it is seen as more natural than other artificial sweeteners. It belongs to a category of sweeteners called sugar alcohols that include xylitol and sorbitol. These are organic compounds derived from sugars through chemical reactions. And they're popular in a variety of foods, and they're often marketed to diabetics because they don't impact your glucose, blood glucose profile in the same way. So there was a study that came out in Nature, which was a very high profile publication, and they trumpeted an association between higher intakes of erythritol, well, no, I should say higher blood levels of erythritol, and a greater risk of cardiovascular events. And they presented a potential mechanism relating to clotting, why that might be the case. So I think this got headlines for a couple of reasons. One, because fear always sells. And the second thing is, if something comes from Nature journal, it gets a little more clout. And I also think there's an element of vilifying anything unnatural gets traction. We automatically want artificial to be bad and to be proven that you can't have your cake and eat it too, right? So this is an example of that, why it has all those attractive properties, and it really did take off in a lot of pickup for the media on this. So, but whenever you see a headline like this, my first recommendation is to actively look for someone who has a rebuttal or a skeptical response to it. And kudos to my Instagram, algorithm, because that I saw the skepticism before I actually saw the fear coming into my feed. Did you as well? Yeah. So the first skepticism I saw was from Dr. Nicola Guess, who I really respect. She's a diabetes researcher in the UK, and she has a PhD in this area. She works with diabetics, and she's also a registered dietitian. And she was just so, as someone who actually wouldn't often would recommend this as a viable option, in moderation for patients, she was really frustrated to see this substance being vilified. And, and she went on this big tirade about this is junk publishing. Nature shouldn't have even published this. And, that's the problem in the first place, let alone the media picking it up. And so there's a couple. So what are the problems with why this claim is not, doesn't deserve the fear it's incited? So the problem is, the first problem is that this was based on an observational study, which is not a randomized control study. So whenever you have just an observational study, like Jenn mentioned earlier, is you're just looking at, in this case, we'll just be specific. They looked at they followed people who were at risk of heart and stroke events, and they measured a bunch of things in their blood. So it's a little bit of a fishing expedition in the first place. They said, let's follow people who have a high risk of having an event. And then after they have an event, let's look at what was higher in the people who had the events. And so that's kind of how they pulled out erythritol. I mean, I think they had pre-specified a number of things they were going to look at, and erythritol had the strongest association. But that's very different than a randomized control trial where you're pre-specifying two different groups, and that those groups are not different in any other way. So anyways, the first thing is whenever you're using an observational trial, you have to know that you can't jump from correlation to causation. And that's just something you have to always bear in mind with studies like that. And so it's just never okay to make that leap, especially from a single study. You have to always look at the broader body of evidence. So one is that's the general, study design. It was really a discovery study. It wasn't, the first one was a discovery study. It's important to distinguish a discovery study from a validation study. Yeah. They then went on to do supposedly a validation study where they looked at erythritol in several other populations, which is a good next step to do, to take your what you've learned from the first study and apply it in the others. And they found a similar association. So that's encouraging. But then we get into an even bigger problem than the study design. Well, it relates to study design, is that the thing they were using as a marker, erythritol, is not actually a good measure of dietary erythritol. So they were measuring blood levels of erythritol and essentially implying that suggested this was how much they were consuming in their diets, when there's a bunch of reasons to think that the levels of erythritol in their blood are not actually an indicator of how much they were eating of the substance, which was what they were trying to sort of suggest. And the issue here is that our bodies actually do produce erythritol. And not only that, but they're more likely
to... It is natural, right?
Yeah, it's natural. We make erythritol, and not only that, but we make it under situations that might increase our risk for cardiovascular disease. For example, under oxidative stress, under inflammation, in the context of diabetes or obesity. So if all of those conditions can make you produce more erythritol, it could just as easily be reverse the other way around, that the heart attacks were, that it was sort of, that this erythritol was intrinsic erythritol that you were making yourself and nothing to do with how much you were consuming. And that in fact, it was the events were, the reason you had more erythritol was because those were just high risk people who were making more erythritol. So you just have absolutely no clue that it's causally related to how much erythritol you're consuming. So
that's a pretty big limitation.
It's a pretty big limitation. And, this, as usual, the authors mention the limitation, but many times they just don't give it the same weight that it deserves. So I think then they went on to try to prove that this, worked as a mechanism, and they used mouse models and tried to induce clotting. And there's a number of studies with that. But I think just this is one of these contexts where I'm not an expert in this, but from what I've read from others, mice are not a great model for cardiovascular disease. And so you have to take that whole, proof of mechanism with a grain of salt, because it's not a good model system in which to do that, nor is it necessarily at a physiologically relevant dose. That's a very common problem with most studies, is that they're being done in conditions that don't at all mimic what happens in humans, and they don't have the same underlying biology. So I think we're out of time for my rant about that one, but the bottom line is to practice moderation with actual sugar and artificial and synthetic sweeteners. There's not really.
You would still consume it under some sort. You wouldn't avoid it. Is that the bottom?
Yeah, personally, I wouldn't. And my dad's diabetic, and I think he started to use that. And I'm not gonna say, Dad, did you read this headline? Stop it. So I do think with all things, any sweetener, there is a official safe dose, and you can look it up. But most of us are not going to exceed that unless we're having it in multiple foods every day, right? So I'm gonna drop a link to 2 different things. One is where Dr. Nicola Guess, who I mentioned, broke this down in more detail, the weak science behind it. And I also want to drop a link to something called the Science Media Center, which is a cool place to see expert reactions to a news story. And you can see quotes from various experts. And so I've dropped a link to expert reactions to this article. And most of them, they're not necessarily as extreme as Dr. Guest saying this is complete nonsense and utter garbage, but there's mostly it's saying it's a little bit overstated, that maybe we need a little bit of caution, but we already do have a little bit of caution. So I recommend you can read that if you want to learn more about how other experts react. And I'm also going to share a link to the Diabetes UK resource on artificial sweeteners in general. What's their position on that? Because I think that's a big topic we can talk about another time. But I think there's a little bit more fear mongering there than necessary. Absolutely. So I think that is all the time we have for today. I was hoping to fit in a little speed round, but I think we need to honor the half an hour that we committed to. So I will stop there, and thank you all for joining us.
Yeah, thanks for joining us.
And if you have questions, please, go to our website, and you can plug them in on the. Wait, are we at? We're thosnerdygirls.org.
And then thosnerdygirls.org.
Great, and you can also sign up for our newsletter when you're on our website, thosnerdygirls.substack.com. So thanks for being here, and send us your questions. Bye.
Bye. Take care.